And Eunice, you can let everyone in then.
Yeah, sure.
Great. Well, welcome everyone. Hello, good afternoon. Welcome to Auction Therapy and Critical Care, the case-based series, session 4. Today, we're going to be talking about escalation to a higher level of care. Our lead panelist today will be Dr. Papytcho, and with him is Dr. Hope, and Dr. Sipuka will be joining us momentarily. So just a few housekeeping items before we get started. Our programming is based on a foundation of love and respect, so please respond kindly rather than react if you disagree with something. It is everyone's responsibility to keep the webinar a safe space. We will be using the chat function for Q&A, so it's at the bottom of your screen. Please send all your questions through the chat box and feel free to introduce yourself on there, and we will try to answer them as we go along. Please turn on your video if you're able to, and position your webcam effectively to show your face if you're alone, or to capture the whole group if you're with people. If you have IT issues, you can send a message through the chat box to tech support Echo, and they will help you out. The session is being recorded, and your attendance is consent to be recorded, so thank you. And finally, please be mindful of infection and prevention control. Try to limit the number of people joining from one gathering place and practice social distancing. So with that, we're very excited you're here, and I will turn it over to Dr. Papytcho to share today.
Hi, everyone. Thank you for coming to today's session, Escalation to Eye Care. And I would like to encourage all our participants to be very active during this session. We aim to take only 1 hour. So your contribution, your question, you can just drop them in the chat box. And then one of the co-panelists will go through and then we'll bring them up for discussion. So today we are talking for escalation to a high level of care. It has happened before that we are dealing with a patient. We reach a point where we do not be able to offer much. In that condition, in that situation, the escalation can either be within the same hospital or the next nearest hospital where they offer high level of care. We'll try and see our practice change of today. So the main objective is to develop decision-making competences about when to admit patients to the hospital using triage protocols and hospital admission criteria. So define mild, moderate, and severe critical illness from COVID-19 to develop decision-making competence about how to design isolation area for patients with suspected COVID-19, design or follow protocols for escalation of oxygen therapy, decide when a patient need to be evaluated by a senior physician, decide when a patient needs to be evaluated by the ICU team. If no ICU is available, decide if and when a patient can be transferred to high level of care facility, and recognize how critical care can be provided outside of an ICU. Understand when to refer a patient to a higher level of care within the context of available resources. So this patient is a 36-year-old male who presents with 2 days of cough, shortness of breath, and fever. When you check at the change practice objective, you find that it's a very rich one. Hopefully we'll be able to pick enough points to convince ourselves that we really need to change the practice for the best type of care to offer to our patients. So this is a patient who came in with history of so he came to an emergency room. He came to your emergency room with 2-day history of fever, cough, and shortness of breath. In the emergency department, the patient was screened for COVID-19, risk factors, and then he was isolated from other patients, and is wearing a face covering. You arrive to evaluate the patient and realize like, wow, it's your colleague. We are wearing PPE for contact droplets. So the patient admit is short. The patient admit is short of breath and has fever, cough, but denies loss of taste or smell. So the vitals are like temperature 37 degrees Celsius, BP 110/74, heart rate 94, respiratory rate 118, and saturation is 92%. So you place him on oxygen therapy at 5 liters per minute by nasal pump before continuing to obtain a history and performing a physical exam. Alana, please up, or Sarah, sorry. The past medical history is healthy, but has had bronchitis in the past. The past surgical history had the inguinal hernia repaired in 1988. His medication is not on any drug. The family history, the mother is deceased. She died of history of hypertension and diabetes. The father also is a disease. He had the history of emphysema. He has 1 young sister and healthy 2 children. The social history, he works as a general practitioner physician and does not smoke, does not use illicit drugs or alcohol. Otherwise, review of system, it's really, there's nothing positive. On physical exam, you found that on neurological assessment is alert, oriented, and the pupils are equal reacting to light, is able to mobilize all and equally all limbs, and then he has no focal lesions. On airway malampathies 2, is opening his mouth is more than 3 centimeters. The dentition is intact. The thyromental distance is above 6 centimeters. Cardiovascular, the rate is regular, and then there's no murmur, there's no rubs. The capillary refill is less than 2 seconds. On respiratory, when doing auscultation, it has ghost breathing sound in the anterior part of the chest. It's tachypneic to 32 breaths per minute. The abdomen is soft, no tender. The bowel sound are present. He had 2+ edema in bilateral limbs. The skin is warm and dry. You've done a very nice physical examination and your history is very clear. So now here comes a time whereby you are dealing with someone who said to be your colleague for this case. And then here we ask ourselves, would you admit this patient to the hospital or manage at home? Does it have a mild, moderate, or severe disease? You can please drop your opinion in the chat box. Sarah, please, can we click? Wow. So as we said, on the LRC, you have enough information on how to deal with these patients. You all have access to this information. It will help you not only for this presentation, but even for future use. The information that is on the LRC is very rich and very useful for our daily practice. So coming back to our patient, the question is, will you treat him at home or you admit him? And trying to classify what rank, what category do you put in? When you check at the classification that is done, this is what will give you an idea if you have to admit your patient or you treat him as an outside patient. So looking at our colleague, when you check the preclinical presentation, the findings, we can compare them with what the classification that has been done by CDC about COVID cases. So it has a range of clinical manifestation. It goes from no symptoms to critical illness. So in adult with COVID, SARS-CoV-2, they can be grouped into asymptomatic, mild, moderate, severe, or critical presentation. So they are symptomatic, as the term is saying, there's no symptoms at all. The test is positive. On the mouth, the sign of COVID is present, but without shortness of breath. There's no dyspnea. And when you do the chest X-ray, it's purely clean, or CT scan, or any type of imaging that you can do. It's not revealing anything wrong. Those are mild. But this one, I mean, after mild comes the moderate group. These are patients with lower respiratory disease or imaging an SpO2, which is above 94 on room air. The severe case, the SpO2 is less than 94 with a clinical presentation, signs and symptoms of COVID. When you do a PF ratio, it's less than 300 millimeters of mercury. The respiratory rate is at 30 breaths per minute, more than 30 actually, and the lung infiltrates occupying more than 50% of the lungs on the imaging. And the critical patients, they have respiratory failure signs, and then the septic shock. They can also have multiple organ dysfunction. With this description that we've done, how do you think that this patient is presenting can be treated? Like, is it home treatment or it deserves to be admitted? I'm seeing different opinion. It goes for I would admit, moderate, admit, admit, and moderate. So the admission depends on many factors. The asymptomatic mild, definitely there's no need for admission for them. But from moderate and downwards, it now depends on your environment where we are operating from. The ideal is to admit this patient and isolate them as we did with our colleagues. So this patient is presenting a moderate to severe form of presentation. Actually, it needs to be reviewed after a few hours to see its progress. And most likely, it's going to progress into severe case. And then it really needs close attention and following from us as a clinician dealing with him. So after this, we can focus now on the practice change action items. I'm not sure how many of us do have a triaging protocol in the admission room for our COVID patients. If we don't have, it's time to engage everyone who's dealing with COVID patients so that we can have one protocol for admission or triaging. If you cannot, it's available at the province or district level. You can just walk to the office, I'm sure, of the clinical care. They'll be able to give you a protocol that you can utilize at your institution. And then we also have to educate all providers regarding the definition of mild, moderate, and severe. Let's not forget about the critical type of infection so that we are able to provide the best type of care and isolate patients who need to be isolated. If you still have more questions or any comments, continue dropping them in the chat box. Thank you, Sarah, for sharing the guidelines link. You can go to that link and then you have all the information that we just from discussing in more detail at your own time. You can go through it and then you get familiarized with them. After this, I'll call in Dr. Op to come in and talk to us more about the isolation room. And what is it and why is it useful? Dr. Op, please.
Okay, thank you so much, Dr. Papytcho. If you look at the Learning Resource Center, and if you look at our course content today, the isolation room is being referred to as an AIR, that is AIIR. So this is the short form for your airborne infection isolation room. Previously, these rooms used to be called negative pressure isolation rooms. So just before we talk about these rooms, how many of us in our facilities have got access to negative pressure isolation rooms? Is there anyone? If you do, please feel free to post in your chat box about these rooms. Sarah, can you please click on the link so that we can know more about these negative pressure rooms? Okay. All right. This PDF, which Sarah is projecting, is quite an extensive document. It is there on our Learning Resource Center, but for the sake of summary, I'll just summarize so that we can get the key points about negative pressure rooms. So these are rooms, specially dedicated rooms to nurse patients on a one-on-one basis who are suffering from airborne diseases. These are diseases which can be spread through droplet infections or by aerosolization of respiratory droplets. So what happens is that your patient is nursed as a single patient in a room. This room has got limited air communication with the outside rooms. The purpose of this is to protect the healthcare workers and other patients in the hospital. So how do patients in these negative pressure rooms get their oxygen requirements? Air will flow into the room, just as in the picture above, through spaces below the door. However, any exhaust air in this room will leave through special ventilation ducts. So these duct networks will go all the way up to the rooftop and then will be expelled into the environment where it is diluted with environmental air. So this protects the patients and the healthcare workers who are working in that environment. So what else do we need to know about these negative pressure or airborne infection isolation rooms? So the environment in these rooms is controlled. So the pressures, as we said, there's a differential change in the pressure. It is more negative in comparison to the adjacent rooms. That is one. The temperature in these rooms is also closely monitored and regulated. The other thing that we have to talk about is the concept of air changes. So what happens is that as air flows into these rooms, it is well regulated. So the actual amount of air is carefully monitored and calibrated. So we have 3 parameters there which are monitored for these rooms. All of this is to increase safety. But I'm sure if you look at the responses, I'm seeing the responses in the chat box, very few of our hospitals have got these negative pressure rooms. So what do you actually do in our facilities? I think when we go into the breakout sessions, we'll talk more about this. So in reference to the document, Sarah, can you please click on the link? Can you please click on the link now? Okay. So what do you do in your facility if you do not have these negative pressure chambers, or if you do not have these air rooms? So there are a lot of strategies that we're using, especially with the COVID-19 pandemic. There are a lot of factors that you can help, that you can control to minimize the risk of infection. One, the triage system that Dr. Papytcho and Tambwe talked about, that is one thing. So separating patients who have respiratory illnesses from other patients, that's something that you can do. The use of natural ventilation and fans, as we can see in this projection. So you want to make sure that your patients are nursed in an outbuilding with windows wide open and free airflow. The use of fans can also help. So natural ventilation and fans would help you, making sure that you've got directional airflow. You've got, some hospitals have central ventilation system, so this would also help. If you have negative pressure rooms with their own exhaust, this is also helpful. We also use UV, ultraviolet germicidal radiation, to help in disinfecting these rooms. More importantly, the use of PPE, personal protective equipment, is going to help the staff and other patients with non-respiratory conditions as well. So you want to make sure that if your patient is with other patients, or as you are seeing them, they're wearing a face mask, an appropriate face mask, to protect yourself, to protect the next patient as well. So these are some of the strategies that you can use. However, as you go through this document, which Sarah has projected for us, you'll be able to find a lot more strategies that you can use in your facility if you do not have negative pressure rooms. Thank you. Sarah, can we go back to the main presentation? Okay. So these are some of the strategies that we're using, and I think we have used this in a lot of COVID centers around the country in Zambia. A lot of our centers, I think, I'm yet to see any negative pressure room, but we're trying to isolate patients. When a patient is admitted in a COVID ward, try to make sure that patients are adequately distanced, patients are nursed in a big airy ward, repurposing of wards for the purposes of COVID. So you may want to get an outlying building, the MDR, the tuberculosis isolation wards. These are some of the strategies that we're using here in Zambia. Okay. Dr. Papytcho, I think you can move on. Okay. So
Thank you
at the
very
end of
much.
this discussion.
Yes, please carry on.
Okay, thanks.
Thank you.
So at the end of this discussion, what are some of the practice change action points for us to go through? One, very few of our hospitals have got negative pressure rooms or air rooms to nurse patients who have airborne diseases. So one, you have to make the best and the most out of your existing facilities. There are no hospitals which are specifically built for COVID, so we have to repurpose whatever we have. So point number one, you have to assess your isolation protocols at your facility. You have to know where your patients are being isolated within your facility. You need to really use the concept of physical distancing, the use of natural ventilation, and whatever ventilation that you have to protect your patients and also the healthcare workers. Ensure that everyone in the facility, everyone who is coming to the facilities, patients, visitors, our support staff, everyone is aware about infection prevention control and the use of the right PPE, masking up especially. Thank you, Dr. Papytcho.
Thank you, Dr. O, for that wonderful talk on the isolation room. We just hope that as we are building new hospitals with this COVID that has come to teach us so many things, we'll now be putting into consideration isolation room with such features. Now I will call upon Dr. Ndaba, who's with us here. He's gonna tell us more about different type of investigation that you can still do when you examine or receive a COVID patient. Like for our colleagues that we just from admitting, what type of investigation do you think would be more useful so that we do a comprehensive care for the patient? Dr. Ndaba, please take place. Dr. Ndaba, are you there?
Hello.
Yes, please.
Hello.
Carry on, Dr.
Yes,
Ndaba.
Papytcho, can you hear me?
We can, thank you.
Oh, thank you so much. Apologies. Yeah, thank you, thank you. I'm having a bit of, my internet is blinking. I hope it stabilizes. So thank you so much. So following up on the care of our patient who has presented with the above history. And so we need to look at what other additional investigations can we order for this patient as we are looking for the diagnosis. I think we must be quick to mention that in the era of COVID, I think most of us clinicians or healthcare workers in general would have a tendency of thinking that any patient who presents with an airway problem or airway disease would have a tendency of forgetting that there are so many causes of airway disease. And so we would be thinking COVID, COVID, COVID. So I think the most important thing for us is to always have a broad mind at the same time as obviously thinking about the most obvious causes. And in this case, we have COVID, but we still need to look for other potential causes of a disease that may have similar presentation as the patient that we have now. So in addition to your nasopharyngeal swab for COVID, as you investigate this patient, there are other key investigations that you may decide to do as you assess the patient. And looking at this patient who presents with a cough, fever, and shortness of breath, one key investigation that you would want to immediately do is a chest X-ray. A chest X-ray is one of the most important investigations for airway or respiratory disease because it can give you so much information. And based on the severity of the disease, you can also pick out information that may affect management, the course of management and course of treatment of this patient. So you want to do a chest X-ray so that you look for features of pneumonia and features of other airway disease. You also want to, this is a patient who has a cough. If they are able to expectorate sputum, you also want to look at sputum and send it to the lab for microscopy, culture, and sensitivity, because it can be anything at this particular point. And so we have to be broad in our thinking. You can do other baseline investigations, such as a full blood count. A full blood count, if you talk about COVID, you look for certain cues or clues that can give you sort of an idea of what is going on. When you look at the white cell count, it may either be raised or it may be low, depending on the stage of infection. And the lymphocytes, most of the time, they are elevated. You can do your baseline kidney function tests or liver function tests. Remember, if this patient is COVID, when you look at the liver function test, the liver enzymes in a significant number of patients initially may be elevated. You do your urea creatinine as well, because we know that one of the severe complications of COVID-19 is the acute kidney injury. And so you may do the U&Es as baselines and also just investigating to see the kidney function at this stage. Then you can do other things like your RVT retroviral test. Remember, you want to manage this patient holistically, and you want to have an idea or as to whether they have any other comorbidities that may affect the way you manage this patient. Don't forget your random blood sugar or fasting blood sugar if the patient hasn't eaten. Order that, and this is a patient with some risk factors in the family history. And so we want to know what the random blood sugar or fasting blood sugar is. And we know these days that COVID is strongly associated with hyperglycemia. A good number of patients will present with hyperglycemia associated with COVID-19. And so that's also a very important investigation as well to look at. You can also look at inflammatory markers. Remember that COVID is basically an inflammatory process that accounts for most of the symptoms that we see. And so if you have access to further investigations such as your C-reactive protein, you can do that, and it will give you an idea if it's raised. You will know at what stage of infection you are dealing with. Then if you can also do D-dimers, it will give you a clue on the coagulation system, because the higher the D-dimers, we know that the higher the risk of forming clots. And we know that thromboembolic events are also a common complication of COVID infection. So with this patient who is presenting with some signs of disease severity, you want to know those investigations as well. So at the end of the day, the idea is to have a holistic approach to the patient. And as much as you are investigating for COVID, don't forget to investigate for other causes as well. Thank you, Dr. Papytcho. I don't know if you have anything to add, Dr. Piri.
I think you've said all that we should discuss on the investigation. Remember, the investigation that we do also depend on what is available at our respective institution. What you've mentioned then, those are the norms that we have to do during investigation of a COVID-19 patient. But for different reasons, we might not have all of these required investigation available at our institution. Thank you. For the case update.
Yeah.
Yes, Dr.
Papytcho,
can you give us the update?
Yes. Okay, just one quick comment on I think on the interpretation of the chest X-ray as well. It's important that our participants have